Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and I hope that you've enjoyed previous session of this amazing program with great lineup of speakers from around the world, which made it very interesting that so many audience, so many people, practitioners from around the world have the chance to get online and on a very scheduled based program every Friday, enjoy the latest developments and the latest data from the greatest speakers from around the world. And today we have a very interesting topic that I believe sometimes we forget about it, and we forget about what are the available tools that we have and how we can increase the predictability of our patients' treatment outcome, and how we can increase the aesthetics by very simple procedures. And sometimes we want to just make it more complicated without any specific reason. So today is one of those days that with this great topic, we have the chance to understand how we can develop the site for aesthetic implant placement, and even without implant placement, just for aesthetic of the patient and restorative point of view. And that's the topic with tooth and a string, magical biodynamics of the teeth, that will be presented by a very dear friend, Nadim Aboujaoude from beautiful Beirut. First of all, hello Nadim, and welcome to Hot Seat.
Thank you, Omid. It's a pleasure to be with you and on this hot seat. I'm gonna bring it hotter, as you noticed from the topic. It's a string, but don't go far with your imagination. A string is not the string that you think about. I'm gonna use another string. It's a pleasure to join on the hot seat, which is the a very interesting, and the way you present it is even more interesting.
Thank you so much, my friend. And I would like to use this opportunity to pay official tribute to all people in Beirut, beautiful Lebanon, for unfortunately the thing happened like weeks ago. And our prayers with all people there, with you, my friend. And I hope the situation gets very well very soon, and hope you all be great as always. And we all pray for the beautiful Beirut and beautiful Lebanon.
Thank you, Amit. No words, no pictures, no videos can tell you the immensity of the disaster that we had in Beirut. It was it's like a doomsday. Fortunately, what we have in Lebanon is the community, where the whole people gathered. Do you know, even if they don't know the person, they were all in one hand, in one hand, helping each other, sheltering each other. And, 5 hospitals were completely destroyed in this area. Even the blast was heard in Cyprus. Even a shattered glass was in Limassol. So it's 300 kilometers away. The blast was considered the 3rd biggest blast after Hiroshima and Nagasaki. So I don't know if I can describe this as the biggest non-atomic blast in the world.
Wow, wow. It's so sad. It's so sad, definitely. But we all hope things get better. And the thing that you describe is truly humanity. And at least it's very happy to hear that people help each other for better living and for survival. And at least that's the good thing to hear, that humanity still exists and people help each other to make everything gets better. So Nadim, once again, I'm so happy to have you, my friend. And we are truly interested and excited for this topic presented by you, because you're one of those people that are really expert in this field and really focused on it. So who can be better than you to present such a topic for our audience around the world. So we are ready from the head to toe to hear your presentation, and you can share your screen, my friend.
Thank you. It's not for nothing that we were called Phoenicians. You know, the Phoenicians are the people who related to the phoenix. The phoenix is the mythical bird that revives from its ashes. And I'm going to start the presentation with a picture of the blast that gives you an idea of the immensity of this destruction that happened to Beirut. But the radius, as you can see here, the dark red is the center of the blast, which is the port of Beirut. And this is the heavy damage that we encountered and damage reported all around this area. We have 300,000 people displaced. And we had more than 100,000 houses completely destroyed, 5 hospitals, and more than 200 deaths, and more than 6,000 people injured. And the injuries, we take by that the major injuries, because the minor injuries were not reported properly. So to catch up with the presentation, I'm gonna give you a short background about I mainly publish about is how orthodontics can help us in our daily practice. And here we published this chapter in the book of John Bumer, Fundamentals of Implant Dentistry, Prosthodontic Principles, published by Quintessence. And along with Professor Nabil Barakat, that you will hear about, from him soon enough, and Dr. Roy Sabri, who is the orthodontist, we published the Implant and Orthodontics, a Symbiotic Partnership. Unfortunately, the update was due to come out in February 2020, but due to the pandemic, COVID-19 pandemic issue, it was reported to 2021. The importance of the tooth is not just the tooth, it's what is surrounding the tooth, the periodontal ligament. Because once you have the tooth, you have all the bone surrounding it. Once we lose the tooth, we lose a lot, mainly the bone that surrounds the tooth. With the string I have in mind is not the string that you have in mind. Actually, the string that I will be talking about will be the function of the string actually is to stretch and to extend. And it's a transitive verb that we will be using. A tooth and the string could be used, as you remember when we were children, we used to hook it to the door and close the door to extract a primary tooth. But the thing I have in mind is related to the article that was published by Ingber in the mid-70s about the forced eruption. And it's how he used it to store non-restorable teeth and mainly to reduce the pockets. So the indications, according to Ingber, were restoring biological width for restoration, recreating the biological width, and reducing the pocketing. But we found during our applications that we can have different type of applications and extend the application that was initially initiated by Ingber into erupting to save the tooth or erupting to extract the tooth. Or we could have different other applications. So we erupt to save the tooth in order to regain tooth structure, in order to align gingival margins, in order to reduce the periodontal pockets, and also we can align this by erupting the roots. We extract, we erupt to extract, and the best bioengineering technique is the orthodontics technique. Bioengineering is not only just putting bone and building up with the membrane. We can just make the body regenerate its own bone. So to regenerate bone and soft tissue with this technique. And how it goes. Let's take the first example as Ingbert described it. Save the tooth, regain tooth structure. You can see this is a patient who had a trauma, and she fell on the stairs, and she was reluctant to lose the teeth. Actually, she was psychologically affected more than traumatically. So when you have a tooth with a post, usually with a trauma will affect the root to the tip of the post, and it usually breaks at the tip of the post, as you can see in the yellow light, line that it is drawn on the X-ray. So what to do? This a part that is on the palatal part of the root that was fractured, as you can see here on the palatal part, that is the fracture. So if I'm gonna remove this part that goes way beyond the gingival margin, and then extracting the tooth, we're gonna lose the buccal bone as usual. So it will end up with a vertical defect. So, and the patient was refusing to do so. What we proposed to her, that instead of doing an extraction and implant dentistry, why don't we bring the tooth down? And as you can see on the left screen, when you see the gingiva in this way, like a the aging tissue, okay, you see wrinkles on the gingiva, it means that there is no bony support. So extracting this root will end up with a very severe vertical defect. As you can see, the palatal defect also. What we opted for is that to extend this tooth with the string and bring this tooth slowly, not very slowly, because I activated this the eruption every week on a weekly basis. On the same day, we changed the elastic band, and you can see the progress of the eruption to a point where we were able not to extract the tooth, but to keep the tooth. We had enough ferrule effect, we had enough tooth structure, and instead of extracting the tooth, we connected the tooth to the lateral central incisor, and this is the progress on the clinical issue. And once we have enough soft tissue that is coming down, what will happen? We can do just a simple fibrotomy, no need to do a surgery, just simple, that will stretch again the tooth and recreate the ferrule effect without having to do a severe surgical treatment. You have enough structure, buccally, palatally. You will tell me that the level of the gingiva is not at the same level of the adjacent tooth. Yes, I don't mind. The patient did not mind, simply because her smile does not show. And we restored this tooth, we saved the root, and we restored the patient smile with simple erupting technique. What did we achieve? We saved the tooth, and we had enough tooth structure to make a ferrule that will protect the tooth from fracture. Could it be applied in the posterior sector? Yes, it could be applied in the posterior sector. Look at this premolar. This is a premolar that we told the patient to extract. But the patient said, I'm not losing a tooth because I have a bad experience with implants. Let's see the X-ray. She has a kind of periodontitis here, and the tooth was a very short root. She said, I take all the responsibility of saving the tooth. We stretch the tooth. In this area, we don't need to have a aesthetic eruption. We can just do it with this type of band without touching the adjacent teeth, if the occlusion permits. And having a simple composite here would stabilize the string in a position of the direction of the eruption. And you can see, what did we do? We brought up the tooth to the level of the wire, occlusal wire, and I would like you to see how much tooth structure we gain. No need to extract the tooth. We were able to build up the tooth and do a crown on a tooth where the patient was suffering of the peri-implantitis next to it. So there is no point of an implant in this position of the premolar. Moreover, what did we achieve? Look at what we did achieve. Definitely we saved the tooth. Definitely we created a ferrule, but most importantly, we were almost at 0 or 1 millimeter of attached gingiva with a Stillman fissure on the gingiva. Look what happened. We stretched the attached gingiva and we have a much more band of attached gingiva around this tooth. Compare between the before and after this, in this case. Let me tell you the story of a premolar. This is the premolar of, this is the molar, the first molar of a, the husband of a colleague. He encountered a fracture of the mesial root of the first molar. Extracting the first molar was not accepted by his wife. So what we did is hemisection, and we used a bridge between this root of the molar and the premolar that functioned very well for the 9 years. After 9 years, we experienced decay of the premolar. Again, what can we do? Extract the 2 roots and place 2 implants. That was replaced, refused by the patient and his wife, who is a dentist. So what to do? I started doing the eruption. Can you evaluate the amount of eruption that we were looking for? But the most important is analyzing the X-rays before jumping into treatment planning. We have the data. Can you see anything on this X-ray? Look at it. I'm blowing it up. You can see the periodontium on the premolar going all the way, touching the adjacent premolar. Let's blow it with the line, and you can see that the root has a hook that goes all the way to the next premolar. Extracting the premolar and placing an implant would jeopardize the situation of the adjacent first premolar. So by doing the eruption that we did, that went on activation on every week basis, we were able to bring up the premolar to a point where it was stabilized. So you ask me, how much do you activate and how much do you stabilize? I would activate until I get to this amount that I need. Can you see that the premolar started with a bony defect, infrabony decay, and ended up with a suprabony, and we restored the biological width. Now we have enough ferrule effect to be able to make the bridge. How much do we stabilize? Double the time of the activation, not exceeding 8 weeks, because 8 weeks, 2 months, we have enough remodeling of the bone that goes from woven bone to lamellar bone that will stabilize the root in its position. Now the tooth is in function for the last couple of years, and it will last for much longer than that. Later, we'll be able to place the implant at a different stage. We saved the remaining root. We created an effect. A patient has postponed implant placement, knowing that these days every patient has the peri-implantitis fear, which is almost a pandemic these days. What's the story of this molar? This molar is suffering from an external resorption, and actually this is a molar. The first molar was extracted at an early age. As you know, when we extract the first molar at an early age, the second molar tilt mesially, and we have a very difficult occlusal scheme. This was restored with the crown at some point, and we, on the buccal side, we don't have much attached gingiva. So what happened here? We have an external resorption. What can we do? Extract the tooth, place an implant, but we don't have enough attached gingiva, and the level of the implant would be much lower than the adjacent teeth. We have a concavity on this issue. So what can we do for this molar? Definitely a root canal, not extraction. A root canal would help us much more, and we will do a forced eruption with a certain direction of the eruption. We will do it in a mesial direction to avoid the proximity, the root proximity that we have between the wisdom tooth and the second molar. By doing so, we were able to bring this molar away from the wisdom tooth and closely to the premolar and more coronal, which helped us in reducing the angular defect on the mesial part of the molar into a straight line with no angular defect, and you will see that we were able to correct the pontic area into a straight line bony defect away from the molar, and there is no more root proximity between the wisdom tooth and the second molar. How stable could it be? It's been stable for the last 10 years or so. This angle defect was used and the proximity between the roots was solved. Can we do it on different molars? Yes, providing that don't have too much hooks on the roots. This is the situation of the missing first molar. The periodontist I work with refused to extract this molar and asked me to do the ortho eruption, and this is what we did. Again, we moved the molar away from the wisdom tooth, and we reduced the problem of the proximity, correcting the angular defect, and you will see now on the clinical picture what happened on the attached gingiva. This is how we finalized the case. No angular defects anymore, bone level properly arranged, and you can see that this is the situation in the area where the molar was too deep and there is no buccal sulcus. Now we have a buccal sulcus with an attached band of gingiva that will protect the tooth from periodontal problems. So gingival alignment, ferrule effect, buccal sulcus. What can we do with this eruption? We can align gingival margins. Look at this patient who presented correct for the smile correction, and you can see that she has a lateral and a central that are much longer than the canine and the premolars. So this is at a close view of her smile. What kind of surgery and what kind of treatment can arrange her smile? The only thing that we can do is that if we do a forced eruption on the lateral incisor on number 12, we will be able to bring it to a proper alignment with the adjacent teeth. Now, with a simple eruption on the upper right lateral, we were able to bring her into this type of temporaries. And then from this type of temporaries with the lateral views, we were able to move to the final restorations, and this final restoration before and after on the lateral views. So the best bioengineering technique is the ortho eruption. Orthodontics is the best bioengineering technique. So gingival alignment, ferrule effect. 14 years post-op. She's not brushing very well on the central incisor, but 14 years post-op. Can you imagine the stability that we have? Guarantee this on any other technique? Aligning gingival margins. Also, this is the assistant of a fellow periodontist. She presented correct the premolar. By changing this crown, if I'm going to put another crown, this crown would be very long in her spine. So what can we do? This is its situation. This is the occlusion. Definitely we can reduce the tip of the premolar, but the extension of the gingival margin will be too much, and it will catch the eye when it is showing. Actually, this molar have this kind of periodontal profile because it is buccally tilted, and the crown was done to correct the malposition of the premolar. We could have done orthodontics, but in this situation, after the tooth have been crowned, we were able to do forced eruption. I'd like you to understand what happens with the forced eruption. Look at this case very closely. When we do the eruption, we definitely align the gingiva, yes. But can you look closely what happened on the gingival margin? Here, you see some calculus showing, and this is the margin of the preparation that you had at the gingival level or slightly below the gingiva. Slightly below the gingiva. So the thing is that when we do the eruption, the tooth starts coming out from the gingiva, unfolding the pocket. When the pocket finishes unfolding, then the gingiva will start coming. So we cannot hope for a gingival eruption or leveling until the full pocket comes out. When the pocket comes to a zero pocketing, then the bone will start coming and the gingiva will start coming. And that's why we had the preparation line that was below the gingiva came out, and then the root that was in the pocket came out with the calculus along with it. And now we have zero pocketing. At this point, we will be able to put down a new crown, finalize the case in this issue. Gingival alignment, tooth alignment, pocket reduction, and we finalize the case. Let's make it more complicated. Aligning teeth and gingiva is very important. Look at this patient who had missing lateral, and the canine took the position, almost the position of the laterals. We know that when we have missing laterals, end up with diastemas between the central incisors and the adjacent canines, and between the central incisors themselves. So here I'm going to talk about the instant orthodontic, which is taking the burr and preparing the teeth, whether for a veneer preparation or for a crown preparation, and interdisciplinary approach. Look at this case closely. This is what we call instant orthodontics. They took the burr, they cut the teeth, and hoping with pink aesthetics to give him a nice aesthetics. But the tooth is in the embrasure. The tooth is dead in the embrasure. How can he clean? He was complaining about all the aesthetics that was not accepted by his standard. So this is the X-ray. These are the X-rays that we have. It is an anterior issue complicated with the posterior complications of the supporting teeth. We're going to lose all the posterior support due to fractures in the posterior support. How can we manage the anteriors? So what we did, before extracting the anterior, we did manage a forced eruption on the lateral, right lateral incisor to level the gingiva. And in this issue, when we bring it down, don't forget, this is a canine. We bring the canine down. The root is conical. When we bring the root down, we are bringing the root to a smaller diameter, thus bringing the canine into a shape of a lateral that is more interesting in this issue. We came to the proper level, as you can see. What happened on the other side? The other side, we said that the tooth was in the embrasure. The tooth in the embrasure, so the vector of the eruption had to be more mesially to bring the tooth closer to the central incisor. That's why the anchorage point was more mesial compared to the straight eruption. So while erupting, the tooth was coming more closely, as you can see, to the central incisor and more coronally, bringing it to a smaller diameter. You can see now the tooth is away from the distal contact, and more closely to the central incisor. And this way, we positioned this canine, which is a lateral now, in a proper position of a lateral, and bringing the case to a simpler treatment. This is in the posterior area. We avoided placing implants in the sinus or a sinus lift. And you can see here the final result that we obtained with no pink ceramic. This is the pictures, the treatment, the final treatment, and this is the case to compare with the before and after. This is the smile of the patient before and after, and we have definitely a happier patient now. What did we achieve? Gingival alignment, tooth alignment, and most importantly, we positioned the tooth in a proper place. This is the picture of a happy smile. So what can we do more? We can erupt to extract. Erupting to extract, this is the situation of a lateral incisor on a full mouth restoration. As you can see, we have two implants on the premolars. We have a canine, natural tooth, central incisor, and central incisor natural teeth. The fracture happened. The fracture reaches all the way to, if we're gonna extract it, there is no buccal bone. Let's look at it. It goes all the way to the tip of the post. Extracting the tooth is no option, because if we're gonna do an extraction, we're gonna lose all the buccal bone, and if we're gonna restore it, it's going to be a big flap to bone graft this area. Why don't we do what we learned how to do? This is the bone level, and it goes more deeper. When we removed only the buccal part of the root, we ended up with a buccal depression. Eruption. Eruption without touching the adjacent teeth, just bonding to adjacent teeth with a palatal wire that goes slightly palatal, because eruption needs to go slightly palatal. If you go buccal, you defeat the purpose, because you're going to lose the buccal bone. The eruption has to come slightly buccal to recreate more bone on the buccal and thicker gingiva. You will see what will happen. This case took a little bit more to activate, because as you can see, the root is hooked. So it took us 15 days to start moving. Then when it started moving, it came along to a point where, look at the papilla. We have excess of bone in the papilla. We have excess of soft tissue. You will understand the importance of the soft tissue excess. Now the gingival level is down. Now we have enough soft tissue. The mucogingival line did not change. If we would have done any bone graft, the mucogingival line would have changed dramatically. Implant placement without a flap. Let me go back one slide. You will see that the diameter of the tooth is slightly smaller. Now the implant has a bony contact all the way. There is no gap that you have to worry about. The implant was placed slightly palatal, and you will see that this is the result that we achieved with a flapless surgery, with a no bone graft, and we did not change any of the adjacent crowns. Touching the scalpel or touching the blade have obliged us to change practically most of the crowns that are in the mouth of this patient. What did we achieve? As you can see here throughout the time, we achieved a gingival alignment, we simplified the surgery and the prosthetic result. And we saved the adjacent teeth, saved money and time for this patient. This patient presented with a diastema on the central incisors and a mobility on the upper left central incisor. When we removed the bridge, look at the type of the preparation that we saw underneath. We could not detect a margin on the left central incisor. Look at the gingiva. When you see wrinkles on the gingiva, it means there is no bone. If we're going to extract the tooth and make any kind of bone graft, the mucogingival line will change, and it will be a very complex surgery. Why not? This is the level of the tooth, so the level of the bone is 3 millimeters away. So if we're going to extract it, it would be a dramatic situation, erupting the tooth. Here, we did not anchor on the opposing tooth, and what we experienced is a tilting. So I would advise you to have 2-point anchors, one on each side of teeth that you have to erupt. And then we brought this was like 10 years ago or more than years ago, 15 years ago, I guess. We brought the tooth all the way down to the anchoring wire. At the activation space of every week, to a point where we had enough ferrule effect to keep the tooth in position for a long period, which is 9 years. 9 years later, this tooth, because this patient refused to connect the teeth together, broke. If we had a connection between the adjacent teeth, this tooth would have lasted much longer than 9 years. 9 years later, we had saved the tooth 9 years. We gave the patient 9 years before coming to an implant placement. So this is the situation after 9 years where we had the fracture, an implant was placed, because already everything was ready for the implant. We had enough buccal bone because the tooth was erupted palatally. The buccally was not affected. We were able to place immediately the implant and finalize the case. Let's get more complicated to regenerate bone and soft tissue. I'm going to open a parenthesis here. When we have two implants next to each other, sometimes we have an intrusion of the tooth in between. This is the case of this patient who had this incisor. The last case you have seen had an intrusion of the first premolar. So what to do in this case? Are we going to extract this premolar and end up with a anesthetic gingival level of the premolar? Can we bone graft this area? Why to bone graft? We have the best potential of erupting the tooth that will bring with it all the bone that is possible, and you will see that the gingiva that was at this level was brought down to a level that is more accepted as a pont level, better than any bone graft, and all this within a couple of weeks. We stabilize the position. Once the bone has removed, then we will extract, and then look at it. What was supposed to be a bone resorption on this implant ended up to be a bone apposition on both implants, on both sides. Look at it. At the beginning, we had the bone at the first thread. We end up with bone at a different thread, but much coronal than the bone that we started with. Gingival alignment, bone leveling, then extension. The tooth intrusion that we mentioned happens also in the molars. This is a tooth that is squeezed between two implants. This implant was placed at a certain time, much later than the implant in the posterior area. And for a complete year, the patient was complaining of a tenderness in this area. When she came back, because she was abroad, she came back 12 months later, 1 year later. I noticed on the x-ray that the tooth has a different position than the x-ray that was before. Look at the contact point, it's much deeper. I went into the clinical and I saw that the tooth was really intruded. So what can I do in this situation? What did I do? I thought, what can I do? Change the crown, but it intruded. I asked the patient, may I try some? She said, okay. I relieved the contact point on the mesial side of the molar. 3 months later, the tooth came into occlusion. Do I have an explanation? No. But the only thing I can think of is that the direction of the contact points with the movement and this during the mastication can either intrude if it is a convergent contact point, or if it is a parallel or slightly open, it will have an extrusion effect on the adjacent teeth. It has to be proven. I don't know if we can prove this. But if we have a tooth that's fractured on this very high smile line, what do we do? Do we do an extraction? Do we do a bone graft? But this is a patient who has a smile line. What will happen to the gingiva? What will happen to the mucogingival line? With the bony defect that is buccal, as you will see on the fracture line, multiple fractures on this tooth, but the deepest was on the buccal, which is almost 15 millimeters. So the buccal bone, back part of the tooth was absent. So if we extract this tooth, it will be a very complex surgery to build it up with the changes in the mucogingival line. Why don't we do a forced eruption? And in this case, we only need a forced eruption in a vertical direction, but in a more lateral position. That's why we were able to do it. And look what happened. We we erupted to extract, but we leveled the gingiva and the bone as at the perfect situation for a bridge. As you can see, the patient's smile was saved without doing anything, without doing any type of surgery. So we did do a site development. And we will finish with the last chapter where we can take papilla and look at this. This is a central incisor. The surgeon did extensive surgeries to build up the bone and place an implant. Ended up with mid-facial aesthetics, a problem on the lateral, and no papilla. And the patient was crying. 6 months later, nothing was coming down. So what did we do? We did eruption. We did the eruption. Look at it. It built bone. It built bone over the implant. It brought the bone over the implant. It's true that the tooth is very short. Yes, it's true. Look what we did. We did a nice architecture of the gingiva by this eruption. And we have the peaks at the same level. Look at the before and after without touching anything. And this is 7 years later. 7 years later. Look at the bone level that we gained at this level. We gained this bone level and it's still there. And it is 7 years later in the aesthetic area. Saving the remaining tooth, gingival level. We know that if we're going to lose 2 adjacent teeth, we're going to lose the papilla, and we restored the papilla. A patient presents with the papilla missing. Look at it. 2 natural teeth with crowns. How can we do it? What type of surgery will bring back this papilla? We definitely cleaning and scaling. If we do the cleaning and scaling, can we get a papilla? We will only get a palatal papilla, not a buccal papilla. So we did the eruption. Here we did not use a hook. I just perforated the tooth and used them. And this is how we brought them. Look at it. We brought them to a level with 2 activations, the central, the lateral and the canine. But the thing happened that the lateral was more quicker to respond. It came down to a point where we had another activation on the canine. As you can see, again, this was the preparations under gingival level. It came out because there was a pocketing. So the pocket unfolded and then the soft tissue started to come down. And you can see here, the before, this is after we gained even the papilla. And this is the level of the preparation, which is more coronal now. And this is the temporaries. These are the temporaries. This is the final restoration or the final architecture before the placement of the final restoration. And you will see that without any type of surgery, we were able to bring down the whole complex of biological complex, is bone, soft tissue, and papilla. And this way we were able to reconstruct the papilla, and you can see that maturation of the papilla throughout the time. And this is the smile of the patient that you can see with all the papilla in. Gingival leveling, papilla relations. Gingival defects, they are common, but if we extract, we will end up with very complex situation. Pink ceramic is not the solution. Look how ugly it is, especially when the demarcation line will show. So for that, eruption, but this was the old times when I used to do with the orthodontic appliance, and it was a slow movement. You don't need the slow movement. Every week activation is good enough, but the most important is the stabilization. And in this case, we were able to erupt both central and lateral, and look what we got. At this point, we were able to give the surgeon a guide for the gingival surgery that we will use as a custom-made surgery. We will mark the level of the gingiva that we will need to cut and finalize the situation of the patient with this kind of smile aesthetics instead of this type of aesthetics. As you can see, this is how we finalize the situation of a happy patient without any kind of ceramic pink aesthetics. Implant site development. Implant site development, this is a gummy smile. The patient a trauma, facial trauma, and she had a tooth re-implanted, okay? And she had a tooth re-implanted, which is left central incisor. But she had missing papilla, and she had a gummy smile. How can we restore her missing papilla? I was able to reconstruct her history. These were brought up from her previous dentist. And then this was the tooth, the left center that was re-implanted and followed throughout the years. As you can see, we started having an external resorption on the upper mesial, on the upper left incisor. That was at the time restored by with composite by the treating doctor. But when I started seeing her in 2012, I started detecting a palatal resorption on the central incisor, on the right central incisor, to a point where this resorption was severe and we were going to lose the crown. So erupting was because if we had the severe resorption on the palatal, we extract the root, we're going to lose all the buccal bone. Erupting the root to a point where we have an excess of tissue on the midfacial, not only on the midfacial, but also on the papilla, you will see that we have enough tissue to place the implant. Now we stabilize the root for 2 months. After the 2 months, we will immediately extract with the periotome the tooth without touching the buccal bone and place the implant slightly buccally. As you can see, look how much soft tissue and bone we have here. I'm not a surgeon. I let you surgeons with the gap, whether you place bone graft or not. And then we were able to restore the patient with an implant side. The lateral incisor, again, a forced eruption was used to bring down the tooth outside the bony envelope. And we didn't do them at the same time because this tooth that was an anchor was a weak tooth. For that, we did only the central. Later on, we did the lateral, and you will see the final result as restored with the papilla and all the aesthetic that we can see. This was in 2014. We can have a 4 years post-op, and now we have a 6 years post-op of the treatment of this patient. Simplifying the implant placement, gingival leveling, and papilla restoration. This is her smile at the end of the treatment in 2018. Let's complicate the situation with this case, as would be our final case. This is a patient who presented with two missing lateral incisor, congenitally missing lateral incisor, and the diastema on a bridge. When we see a diastema on a bridge, it means two things: either a severe periodontal defect or a fracture of the central incisor, and which is confirmed by the panoramic X-ray. You see the angular defect here that connects with the missing lateral side. Not only that, if you look closely on the X-rays, you see that she has a huge nasopalatine, and the incisive canal here is very big. As you can see it here, it is so big that it connects with on the palatal side with the defect that we have on the fracture. So what do? Do we extract for this case? Look at it. This is the patient. She has a V-shaped maxilla, and she needs desperately a lip support. Look at it. If we extract the central incisor, what kind of treatment can we restore this situation? And what kind of gingival tissue surgery we will have? We did a eruption, so connected the fractured part together, and I was not able to have a root anchorage, so I used a pin that we used to use for amalgam, and I erupted this root to a point where we had more soft tissue than what we needed. And at the point, we extracted the fractured part and then another eruption, and you can see that we did not have enough bone in this area. So what we did is we built a separating wall between the nasopalatine and the bony defect buccally that we had. For that, later on, the surgery was simply an only graft instead of a 3D reconstruction. We were able to do an only graft, and you can see the amount of bony wall we recreated separating the two defects. And the only graft was used, and we can see there is no changes in the mucogingival level because we had prepared all the soft tissue. This is how we finalized. And then when we had the temporaries placed on the implants, she started complaining of this natural tooth. So for that, again, we did another eruption of the natural tooth to level gingiva on both teeth, and you can see the smile of the patient at the end of the treatment. This is the final restorations, and this is what we ended up with. Definitely we have a small missing tip because we have two adjacent teeth missing. So the papilla would disappear where we have missing teeth. Luckily, the lip will cover this, and this is 2019 with a steady and stable result until now. We simplified the implant. This treatment, we leveled the gingiva, we had a papilla restoration. I will finish with this quickly. Look at the amount of this, and if you look at the X-ray, you will see that the central incisor is a lost tooth. But a lost tooth is not a useless tooth. Look what we could do. We can bring the tooth down along with the lateral incisors to a point where we would extract the central incisor, and we have enough soft tissue to do a final bridge. Unfortunately, this was not my bridge. This is the prosthodontist's bridge. The referring prosthodontist, he could have done with less on the gingiva, and we would have had a very nice result. In the conclusion, try to save the tooth. The periodontium is your best ally. Use the tooth to regenerate bone and soft tissue. Omid, I think this is your topic. You're a periodontist, and I think you would appreciate very much how this type of treatment. Thank you very much for listening.
Thank you so much, Nadim. Absolutely, I appreciate it because, you know, this is a very, very interesting topic, and usually we don't hear it that much in podiums, in congresses. You know, so many people don't talk about it often. And one of the people I usually heard talking about it was Maurice Salama, talking about orthodontic site developments and, you know, how to increase the volume of the tissue by using tooth. And also I heard about it from Dennis Tarnow and you, my friend. Some of the practitioners pay enough attention to such protocols, but not all of them. And I think that was a good opportunity for most of us, hearing from you and colleagues like you, expert in this field, that we have very good options to increase the predictability of the outcome that we can achieve in our patients, and sometimes we forget about them. So, you know, your cases was, some of them absolutely was amazing. And one of the things that come to my mind is this: is it easy to convince the patients all the time by these protocols? Because as you described it through cases, and as I understand and my knowledge, we can summarize it that we have three options. Number one, we only want to erupt the tooth and we don't have to do anything with the tissue or the bone. In the cases that we just want to provide a ferrule effect and just restore the case, and there is no aesthetic issue. So in that case, we just erupt the tooth and the force maybe is very rapid and it's very fast, and just the tooth come out and everything stays there. In number two, we can erupt the tooth and erupt the soft tissue, but bone will stay there. So in those cases,
no, everything will follow.
No,
everything.
Yeah, but we have two scenarios.
Excuse me, everything will follow.
Yeah, Nadim, let me tell you about it, because I know everything will follow, but depend on the forces that we apply. For example, correct me if I'm wrong. If I erupt the tooth, if I erupt the root,
yeah,
without circumferential fibrotomy, but with heavy forces, if the force is heavy, the bone movement maybe is nothing or minimal. But if my force is light, then bone can also have the chance to grow. In your experience, does it have to do anything with the force, or no matter if the force is heavy or light, bone will follow the tissue?
That's the point. You hit the nail on the head. The thing is that I noticed no matter what you do, the force is the force. You pull every week, the soft tissue will come, providing you give it enough stability. If you stabilize for 2 weeks, for 8 weeks, or double the time of the eruption, the bone and the soft tissue will come. But the first thing that we notice, that sometimes they tell me that it's not coming. It's not coming because the pocket is unfolding. Once the pocket has unfolded, the soft tissue and the bone will come. The soft tissue and the bone will come no matter how quick you do it. There is what I say, that there is a shift in paradigm. They used to tell us soft eruptions will build bone. No, just stabilizing will build bone, because everything is coming, but you cannot see it on the X-ray. You get enough time, it will calcify and you will see it. If you don't want the bone to follow and the gingiva to follow, just do the fibrotomy. I've seen in the early first case. You just do the fibrotomy, everything will stay up. But if you don't do the fibrotomy, everything will come down. No matter what type of force you use, better use the quick force. And how do I convince my patients? It's very simple. You just tell them, the treat length will be shortened. You'll have a shorter treatment, because if you do bone graft, if you're going to use bone substitute, how much time you need to have for maturation? At the least is 4 months, 4 to 6 months, sometimes 9 months. So I'm giving you everything within 3 months.
So Nadim,
so it's very simple, and there is no surgery. And the thing is that there is a different type of patient according to where you're living. If you're living in your own area, it means that your patients can accept that. But if you're living in an area like the patients come for a quick treatment, or any different area where patients come for what we call it tourism dentistry, this is not an option to be used.
Yeah. So, you know, because I'm very curious about it. So the thing that you said is very interesting because you talked about a stabilization. So in cases that we want the bone to grow also, you
Yeah,
mentioned that we should stabilize and the time is 8 weeks, like 2 months. But
definitely.
yeah, but if we just want to grow the tissue, no matter if the force is heavy or light, just without doing the fibrotomy circumferentially, tissue will grow.
Yeah.
So if
The tissue will come even if you do it with it quickly. But the thing is that you have to understand again that if the root is here under the pocket, here's the pocket,
yeah, yeah,
okay?
yeah.
And you need to do eruption. The tissue will not come down. The root has to come until you get zero biological width, and then now we'll start coming.
Yeah. Yeah.
Soft tissue and bone.
So can we say that the good candidate for this type of treatment is those without pockets or no?
No, everybody is a good candidate because when you do it, you're reducing the pocketing. And that was the first aim of Ingber, if you remember in his article. The first aim was to create a ferrule effect. The second aim was to reduce the pocketing.
So just
but the thing is that I did is I extended the applications of this technique to different, to creating papilla, to managing the soft, for the implant soft tissue, and for implant site management, and for pontic management I did it. But there one thing I can add, I did not illustrate it in the cases. Sometimes you can do the fourth eruption to a point where you don't extract. If it is a tooth that you're going to lose, you erupt it to a point where you can shave it underneath the bone level, and you go again to what Salama has explained, and into pontic management, and you leave the root under in the pontic.
Yeah, like the root submerges technique. You know, use the root to bring the tissue and bone, and then submerge it underneath. So I think the only difference will be in those cases that have pockets comparing to those that they don't is matter of the time, because the time that takes the root to come down along the pocket and then grow the tissue with itself, it takes more time, right? So, and Nadim,
yeah, maybe 1 week or two.
Two. So
only 1 week. It's once. Look, it's like pushing a car. Like pushing a car. First, when you start pushing the car, it's difficult to push it. When the car starts rolling, it's very quick.
Yeah, yeah. And can I have your recommendations on the type of the wire that you use for these cases? Is it the same in all the cases, or depend on the case you change it? I mean, the diameter or the type of
the wire, the anchoring wire is no, the anchoring wire is the same. Is the same that you use 0.8 or 0.9. It's the wire that you use usually for clasp, for acrylic removable partial denture. This is a very simple wire I use. The elastic band is the elastic band that you use for orthotics. It's a continuous band that you just noted. Pull it as much as you can. Pull it as much as you can. Don't be afraid. Don't be afraid. Pull it as much as you can, and make double knots or 3 knots for it not to loosen up. And see if your patient every week.
Yeah, and then
you have to create space between the pontic and the tooth. So if the tooth hits on the temporary tooth, it will not move. You need to create space for it.
Yeah, and you know, in doing the forced eruption, some practitioners do it with brackets, and some people do it with a hook in the root. So in your experience, which one do you find better or easier or more predictable? Or is there no difference even between them?
There is no difference, but the thing is that if you use the brackets, the patient will complain about the aesthetics. Mm-hmm. The way I do with the palatal, and then you have to have a palatal movement. And I need the palatal movement. I need to get away from the buccal to have enough thickness of bone and soft tissue. And if you do it with brackets, you will need an orthodontist. I don't need the orthodontist. I don't have to compromise the aesthetics. I can just do it using the this kind of device or appliance, and positioning it in a palatal position and with an aesthetic shield of the tooth that is to be erupted, and the tooth will erupt behind the shield, providing it does not interfere with the shield. Otherwise, it will block the eruption.
And Nadim, also I want to know, I think you showed it in your cases, but I just came to my mind now. When you are using this hook in the root and you are using that wire attaching to adjacent teeth, from the aesthetic point of view and from the functional point of view, do you always attach that string to the palatal side, I mean to the cingulum part, or it depends?
It depends on the occlusion. If I have enough space, I need to attach it as coronal as possible, as incisal as possible, to create enough space for the root to come. But the most important thing is that the wire, the occlusal anchorage wire, and the hook have to be parallel.
Yeah.
So again, let me show you. It has to be parallel. You cannot put it like this.
Yeah.
Otherwise, the root will erupt twisting. And if you have a bony defect, you lose all the buccal bone. They have to be parallel.
Yeah.
I don't know if it shows. Parallel, not perpendicular, parallel.
That was a great point. I mean, it's a very interesting topic. And you know, in the first section of your presentation, that you decided mostly to do the rapid eruption and just bring the tooth structure out and restore it. You know, some of your cases, the roots were very small. So the remaining root was very small. And you did it even in a post and core and crown on that root, and you saved that root. So this is very interesting for me, because I want to know, because you have the ability to use that root and grow the tissue with it. So why you didn't decide to extract that root after using it for growing of the tissue and place the implant? I mean, when patients come to us and ask for a treatment, some part of it is about the predictability and the aesthetic that we are providing for the patient. And some part of it is about how we see it long term. I mean, like 5 years later, and the survival of that crown on that piece of root, like 10 years later. So do you find it as an option to use the root and then extract the root and place an implant? Or in your practice, even saving those small fragments of roots works good for your patients long term?
Look, these patients were reluctant to lose their teeth. And the thing is that the most important thing is that if you have enough ferrule effect, you will keep the tooth. In my concept of treatment, I would think about implants are here to restore missing teeth, not teeth to be missed.
Yeah.
So I don't extract a tooth when I save it. When I see sometimes the cases that are used in shield, I love these techniques, the socket shield, maybe with the principle. But I hate it when I see the amount of teeth that are extracted.
Yeah.
That are sacrificed for the sake of the socket shield. Do the root eruption, you will keep it. You will not extract it. And if you don't want to keep it, I've managed the site. But unfortunately, the thing is going from quicker, more rewarding dentistry. Take your time, accept the treatment that you would place to your patient in the mouth of your patient as if it is your daughter. It has been said so many times in many lectures. Treat the patient as if he or she are your daughter.
Yeah, I'm totally agree with you, because that's a great.
Let me ask you a question. Let me ask you a question, Omid. Let me ask you a question, Omid. Would you rather have an implant in your mouth or a tooth that I can save?
Definitely a tooth.
So if I gain 10 years, as I showed you, I lose teeth sometimes. 10 years later, what's that? Can you guarantee an implant for life?
No.
We are seeing so much peri-implantitis and complications of implants. Why not saving the teeth and giving a chance before using the implants?
You're absolutely right. I think the best message of today was this, because so many people forget about that they're dentists for saving teeth. And as you said, I agree with you. Sometimes with a small crown lengthening procedure, with a forced eruption, with a good prosto work or endodontics, we can save the tooth. But as you said, in so many areas, it's mostly money-driven protocols and treatments. And, they look at the patient and say, for example, there are so many ways for dentists to convince patients. I can convince you to extract your tooth by saying that, you should pay for this, pay for endo, pay for prosto, pay for periosurgery, and we are not sure how many years it works, so it's better to go and do an implant. So the patient is convinced for implant. Or on the other hand, I can say to the patient, your teeth is your teeth, and you can save them as much as you can, and it's never late for extraction, so I recommend you to save your tooth. And the patient says, I'm very happy with your suggestion, so I want to save my tooth. So it's very easy for dentists to convince the patient the way that they want it to be. But the reality is exactly as you said, because we can treat periodontal diseases very predictably. But when we have a peri-implantitis, I can safely say in more than 70% of the cases, there is no treatment. At least we are just keeping them and just following them up. And we cannot treat them 100%. And even if the defect is contained, if it's not contained, most of the practitioners nowadays prefer to re-explant that implant and do everything again. So I'm very agree with you 100% that why not saving the teeth as much as we can? And it's never late for extraction. We can extract at the time that there is no way for saving the tooth. And that's a great message. And I thank you for that, really.
Thank you, Omid. Coming from you, you're a periodontist, you understand very well what I mean. And you've seen cases, and I invite you, I would like you to invite a friend of mine, a colleague of us, a periodontist, who would show you a follow-up of cases with 3 millimeters of root saved for 30 years and more. And it would be a challenging experience. Thank you very much. I leave you with this picture of Beirut, this lovely picture of Beirut from my house, from my garden. And I love to have Beirut, I'd love to have Beirut back to its glory. Thank you, Omid, for inviting me, and I'm ready for all your direct them to my email that you have. Thank you very much.
Thank you so much, Nadim. It was a pleasure having you with me, my friend. And I'm pretty sure all the audience have enjoyed your beautiful and unique, I have to say, unique presentation, because it is not something that you see often in congresses, in courses, but it's something definitely that we should know if you're practicing in implant dentistry field. So thank you so much again, my friend, and I'm really looking forward to see you very soon. Hats off. Thank you.
Take care. This is not show-off dentist. This is everyday dentistry. And this is not applicable for tourist dentistry. It is applicable for community dentistry.
Exactly.
Thank you very much.
Exactly.
And good night.
Bye-bye.